Good morning, everybody. If I could ask everybody to kindly take their seats. The Committee on Health Policy will now come to order. Anhar, please call the roll and announce the presence of a quorum.
Chair Burton.
Here.
Vice Chair Broder. Here. Senator Albritton. Senator Avila.
Here.
Senator Book. Here. Senator Broxson. Senator Burgess. Here. Senator Caladiot. Here. Senator Davis.
Here.
Senator Garcia. Senator Harrell. Here. Senator Osgood.
Here.
We do have a quorum.
Thank you, Anhar. This is our first committee meeting for this term, this session. So what I'd like to do, even though I think those visiting us today probably know who we are, I'm sure we have friends at home who are watching. So for their benefit, senators, if you wouldn't mind just introducing yourselves briefly. And Senator Harrell, you're the only one to my right, so I think we'll start with you, ma'am.
Thank you. I don't know why nobody wants to sit on this side of the dais, but come join me, anyone. I'm Senator Gail Harrell. I represent District 31, which is Martin, parts of St. Lucie, and part of northern Palm Beach County. And I'm delighted to be here. I've served on this committee for many, many years in the healthcare arena, having been a former healthcare administrator and also do health IT consulting.
Thank you. Senator Osgood?
Thank you and good morning. I'm Senator Rosenhaus, and I represent Senate District 32, which is the East-West District in Broward County. Very excited to be on this committee, having about 23 years of experience working with individuals that are HIV positive in the community with a lot of health disparities.
Thank you. We'll just keep rolling down the desk if that's okay with everybody.
Thank you, Madam Chair. Senator Book, Senate District 35, which is Western Broward County, have been on the Health Policy Committee, I think, since I started in the Florida Senate, and I'm happy to be here under your leadership.
Good morning, everybody. Danny Burgess, Senate District 23, which is East Pasco, East Hillsborough area of the state, East and Central Pasco now. Really cool to see you, Chair Burton, doing kind of what we call a left seat, right seat. You chaired it in the House, and you're just rolling into the Senate and sharing it here. That's good command authority. I love it. Looking forward to working with you.
Thank you, Madam Chair. Senator Avila, I represent Senate District 39, which is Northwest Miami-Dade County. Served many years on healthcare policy committees as well as the Healthcare Appropriations Committee on the House side. So looking forward once again, Madam Chair, under your leadership to be on this committee. Thank you.
Good morning. I am Tracy Davis. I represent District 5 in Jacksonville. Definitely looking forward to serving under Chair Burton's leadership, as has already been said. We served together on health policy in the House along with my other colleagues, and I was actually the ranking Democrat, Chair Burton's sidekick in the House. So looking forward to serving with this body and dealing with some health policy under your leadership. Thank you.
Thank you. And in the back row, our Vice Chair,
That's me.
Senator Broder.
Thank you very much, Madam Chair. Jason Broder, Senate District 10, which is all of Seminole County and part of Orange County. I am one of 5 former health policy chairs in the House, health appropriations chairs, or a children and family chair in the Senate. And so looking forward to working with all of you. I'm a healthcare consultant by trade. I have a degree in public health. And so thanks for having me, Madam Chair.
Thank you, Madam Chair. My name is Alexis Caladiot. I represent Senate District 38, sunny South Florida, Miami from Key Biscayne down to Homestead. It is an honor to serve on this committee under your leadership, Chair Burton, and I look forward to contributing in any way possible to the great work we have in front of us. Thank you, ma'am.
We're happy to see Senator Garcia joined Senator Harrell over on this side. So,
Thank you so much. Senator Garcia for District 36, Miami-Dade. I have the fun part of Miami-Dade. Miami Beach, West Miami, Coral Gables, Westchester, Sweetwater. I am so looking forward to continuing the work. I hear that you've always done such wonderful things on the House side. I've come to do it over on the Senate side and continue to learn from all of my colleagues. Thank you.
Thank you, and good morning, everybody. So I'm Colleen Burton, a senator representing District 12, which is most of Polk County, right in the middle of the state. And you've probably heard I've had a little bit of experience in the health policy area and look forward to continuing to learn and work with my colleagues here on this committee. As we always like to do, we want to remind everybody to please silence your electronic devices. Keep in mind if they vibrate, that makes a noise sometimes too. So let's all silence our electronic devices. If you wish to address the committee, please complete an appearance form and hand it to a member of our sergeant's office. Should you choose to waive your speaking time, your position, if noted, will be included in the committee records. And now we'll move on to what I think is going to be a very interesting agenda. We'll start with our first panel. I'd like to go ahead and invite our panelists to take seats up here at the front. Why don't you all move at once, even the second panel? That way we don't have a lot of movement. I don't know if your names are on the reverse of those, but I think they probably are. All right. Thank you all for joining us here this morning. Members, this first panel discussion is on an innovative approach for providing inpatient hospital care. As I'm sure everybody recalls, last session, the legislature enacted Senate Bill 1222 by our good friend, then Senator Aaron Bean, who is now Congressman Bean. A number of hospitals around the state have received federal and state waivers to implement the new law's provisions for providing inpatient hospital care to patients in their homes. Today, we are delighted to have Dr. Michael Maniaci. I'm going to look at it because I'm better looking there. Thank you. And Dr. Chang. Dr. Maniaci is from Mayo, and Dr. Chang is with Tampa General Hospital. We'll hear from both doctors, and members are invited to ask questions of the doctors and dialogue with them regarding, particularly now we're talking about hospital care at home. Dr. Maniaci, you are recognized, followed by Dr. Chang.
Thank you, Madam Chair, and thank you for your support last year in the House. It was crucial to pass SB 1222, so thank you so much for that and everybody that supported us. That was wonderful. I just want to take 1 minute to tell you about what has happened with SB 1222 and what we've seen at Mayo Clinic and our experience with hospital at home. Since our start of our program in July of 2020, we've seen over 1,800 hospital at home patients at Mayo Clinic. That greatly accelerated by SB 1222 last year as we were able to use other workforce to deliver care in the home setting. So that's been a wonderful experience for our patients. What has this done for the patients and for healthcare in general? Well, it's given our patients freedom and control of their healthcare as opposed to being isolated away from their families, not in control, not getting good communication in a hospital. They're able to go to home and have the hospital come to them. They're able to engage with the healthcare and relieve and get hospital level care in the home setting. That's been really wonderful to them. We've shown at Mayo Clinic equivalent to better mortality rate, readmission rate, less escalations to the ED when they're recovering health, and people recover faster in the home. There's something magic about being at home where there's not stress, you don't have alarms attached to you, there's no beeps going off keeping you up at nighttime. That makes you better faster. You get better, you stay at home, you don't go back to the hospital within 30 days, which is wonderful. What's this done for healthcare? It's provided capacity, it's driving down healthcare costs, it's providing a different way to connect to our workforce. You know, we have a shortage of doctors, we have a huge shortage of nurses. If we keep doing the same thing over and over again, we're gonna lose that battle. We have to do healthcare differently. The virtual aspect of connecting the people, having our core resources of nurses and doctors connect virtually, then others in the workforce with licenses, paramedics, traveling nurses, physical therapists, deliver that care in the home setting, that's magical, and that really has helped our workforce, helped our patients. It's really great. What does the future hold? Continued growth forward, movement into cancer care. You'll hear a little bit later about growing, ED volumes and capacity issues, ED at home and primary care at the home setting in order to keep those patients well, have them activated in the home and keep them there so they don't have to put stress on our EDs and hospital systems. So the right people can come to those hospitals, we can open the beds for the sickest patients that need ICU and surgical care. Working with our partners, gathering research, setting the metric data. Florida's leading that effort. Here in Florida, our Jacksonville Command Center sees over 1,000 patients over the last year in Florida, but almost 700 patients in Wisconsin and in Phoenix, Arizona, taken care of by Florida doctors here in this, so we're leading the way in healthcare with this, which is really exciting. That's what the future holds if we keep pushing forward as a team moving this. I thank you.
Dr. Chang, you're recognized.
Thank you again, Madam Chair, and thank you for having us here today. I agree with everything that Dr. Maniaci said. He stole a bunch of my content. But if you go back to the reason why we started this program, it's really for our patients. It is the best care. When you talk about the things that we'll speak of later today around ED diversion, hospital at home is another cog in the healthcare system that de-silos the care, right? So a patient normally has to think about the mindset of being in a hospital away from their loved ones, away from their pets. They have lives outside of the hospital, but yet when you're in the hospital, you're sort of held captive. Even just getting up to go to the bathroom is a task sometimes, versus being in the comfort of your own home and bringing the hospital to the home. It's a really revolutionary concept that focuses around patient care. And I think one of the most important reasons that we do this is for the transition of care. So you can imagine, let's just paint the picture of a patient that's in the hospital. They're Medicare patients, so they're over 65. Many of our patients are in the late 70s, early 80s. You get a stack of papers and a bag full of medicines. We fill the meds so you don't have to stop at the pharmacy. You leave the hospital, but now transitioning home is a huge step in that process. And if we don't get that 100% right, that patient doesn't have good access to a transition of care, then they unfortunately end up in the emergency department. So imagine now that we're in a hospital at home program where we can actually advise the patient. We actually take pill boxes out to a patient's home and arrange them for them, and then have them do it for the next day and the next day, so we know that they learn how to do it and can support themselves when they're discharged from the hospital at home program. So I think for me, that's been the biggest surprise. We know it's good for patients, but even going out on Christmas Day and seeing a patient be with their grandkids, opening up presents while, getting IV antibiotics is something that's really neat, because that patient would normally be at the confines of the hospital and their family has to come to them. So overall, it's been a really outstanding experience so far. I think working with Dr. Maniaci a little closer in this year is one of our priorities to, as he mentioned, start to pool the data to look at the outcomes, because the outcomes are going to drive this, right? CMS has already said that the cost of healthcare is not increased with hospital at home, because that patient would normally be in the hospital, in the walls of the hospital. So we know that it is a capacity strategy also for Tampa General. That's kind of the second point. When you start to look at the population growth in the area, building another hospital is not always the best thing because of the capital costs and operating costs that are incurred by doing such a thing. So this allows us to sort of decentralize the care and only cover operating costs versus that capital cost of building a brick and mortar hospital.
Thank you, members. Do we have any questions for either of our guest panelists? Senator Brody, you're recognized.
Thank you, Madam Chair. This is fascinating stuff. And curious question on, you had mentioned that you're seeking to reduce readmissions, and that's always the goal. Are there certain procedures or disease states in which you're finding to be the ones that are leading how you're doing future ones that are more complicated? I know, Dr. Chang, you had mentioned that you've already changed a lot of your communications procedures because you've got a lot of post-surgical patients that maybe are in their 70s and being taken care of by somebody who might not remember a rotary dial phone. And so their method of communication may be different if you don't go for that. But do you see certain disease states that are easier to prevent the readmission that are driving some other ones? And what does that look like as you evolve through the more complicated ones?
Dr. Chang.
Sure, thank you. It's a great question. So the common diagnoses that we see in the hospital at home program are things like congestive heart failure. That's one where a patient's lungs gets filled up with fluid because the heart's not pumping right, and you need medicines to help relieve some of that fluid. And in doing so, they live on a razor's edge of getting dehydrated and the kidneys starting to shut down versus them not being able to breathe. And so we've rolled out some interesting technologies to help reduce readmissions and look at fluid levels inside the lung through a sensor. Things like that are hugely important. So I would say congestive heart failure, chronic obstructive pulmonary disease, which is COPD. So usually it strikes former smokers and they're on home oxygen, and same thing, they're very tenuous as far as their care is concerned and how their breathing is at home. So those have been like the two main diagnoses that we dealt with. The way we see this expanding, we're actually inside of Tampa General now starting to meet with all the different service lines. So one thing that's come up is looking at post-kidney transplant patients, taking them home a day or two earlier and easing that transition. Post-valve replacement patients, so some aggressive cardiac procedures that we would normally spend a couple of more days in the hospital, but not only does it save and preserve hospital capacity, but as I mentioned earlier, it helps ease that hospital transition.
Dr. Maniaci, would you like to comment as well?
Yeah, just a couple things to add. I completely agree with what Dr. Chang just said. We started with heart failure, COPD, the main diagnoses that are the most numerous and cause the most readmissions in the healthcare system. We had the same findings of reduced readmissions, 30 to 60% of those patients. Again, it's the ownership. You're in the home, you have the technology, and you're not rushed to get out of the hospital. So you can stay there, keep it in the home, make sure they take their pills. If they need an escalation, if something happens, they go to Cracker Barrel, they get too much food, too much salt, you can escalate the care in the home as having them go back to the emergency room. We found in our patients almost 30% in the first 30 days after being discharged from our home hospital needed something, but we were able to keep 85% of those patients in the home and just treat them there, as opposed to them, they would have come to the ED those other 85% of the time, so that's been wonderful. As we've had success with this, we started to expand to other diagnoses that spend a long time in the hospital. Bone marrow transplants, 15 to 30 days. You get your transplant, you have to sit there. You get labs, it's antibiotics. It's not exciting, but it's for your own safety. But you can catch something from the people next door. Bone marrow transplants now, we do the transplant, day 2, you're at home. The next 30 days, you're at home, getting those infusions, getting those things, being with your family. Post-surgical cares, Dr. Chang has looked into. I had a patient just last year, that spent 90 hospital days after her surgery because of complications. 72 hours was spent in the physical hospital. The other part of that, the other 87 days was in the home setting, but she needed hospital care that whole time. That's the power of the system if you do it correctly.
Senator Harrell?
Thank you so very much, and I think this is just fantastic. Everybody prefers to be at home. And I know Memorial Hospital down in South Florida has a similar program. They call it the Doc in the Box, and they send all the equipment home, and then they have regular visiting technicians or nurses come and specifically. Can you speak to the role that telehealth plays in this and how critical that is to really being able to see what the progress the patient is making and perhaps avert complications that you might not know about if they were just at home without that either technician visit or the telehealth aspect of it?
Whichever one of you would like to respond. Thank you.
Thank you. So yeah, telehealth plays a key role. It's both the virtual connection, physically being able to jump in the home. Our response time of our nurses when the patient pushes a button, less than 30 seconds. Try to get that in a physical hospital, the nurse. I mean, it's very instantaneous. They can escalate to a nurse practitioner, a PA, or a physician instantaneously. Besides the virtual connection where you can monitor in and out, not spying, but watching and there when the patient needs it. Then you have the technical aspects, the blood pressure cuff, the pulse oximeter, the devices that collect biometric data and can feed it to us. So if somebody 5, 10, 15 days into their stay, even though they're discharged from their home hospital, if you have the technology there and they don't feel well, put on the cuff, put on the thing on your finger, let me get some vitals, let me see, do I need to do something? Send a paramedic to the home to do further investigation or just give you a bag of fluid? Or is it critical you need to come to the hospital or clinic to come see us? You can make that determination, Madam Senator, and figure out what needs to be done with the patient, as opposed to just picking up a phone, oh, you don't feel well, come to the emergency room, because that's the answer to everything nowadays, but that's not the answer. This is the answer.
Dr. Chang? Would you like Dr. Chang to answer the first question first? Okay, Dr. Chang.
Yes, so I think the hallmark of our program when we designed it was also built around safety, right? Imagine a patient is inside of a hospital and their inpatient level of care, now taking that level of acuity patient home and having both the patient and our care team feel safe that the care is solid. So we utilize a ton of telehealth. The first thing we utilize is a sensor that sits on the chest that sends biometrics to us at every 5 seconds for blood pressure, heart rate, temperature, and oxygen level. It also recently was FDA approved for cardiac output index, stroke volume, and systemic vascular resistance, which is like ICU level of care monitoring that we're getting at every 5 seconds, including a 1-lead heart monitor EKG. That's streamed. We give the patient a 3G tablet or 4G tablet so they don't have to worry about an internet connection. And that's also our portal to connect via telehealth. And there's 24/7 on-demand telehealth, whether it's the care team reaching out to the patient for an issue we're seeing on the monitor, checking in to see if they're okay, or if a patient realizes something's going on, or a family member and needs to contact our care team. The last thing we did was we've taken care of a handful of patients that live by themselves. And this was a challenge for us as, if you're 84, trying to reach out and get a tablet and call the care team. We put the phone number on a patient bracelet so they can also call us. That's another way. But we actually gave them like an alert bracelet that has a cellular connection that they just hold down the button and they're immediately connected to us. So looking at those three main technologies, that was kind of the highlight of making sure that our program was as safe, and it's really built on the foundation of telehealth and technology.
Follow-up, Senator Harrell.
Thank you so very much, and I am so impressed with this whole concept and how it is moving forward. Delighted to hear what you all are doing. I've seen it in action, and I know how effective it is. But the other aspect of it is reimbursement, and how many does Medicare pay the full hospital level of payment? I know you work under a DRG system, and do you get is that considered part of the DRG? And then also, what do insurance companies do about payment?
Dr. Maniaci.
Sure. So thank you for the question. Yes, under the CMS waiver, the Medicare reimbursement is equivalent. The patient's going to require hospital-level care for that heart failure exacerbation or whatever they have. The same DRG payment for hospital at home applies to the physical hospital. It's exact. It's dollars for dollars, the same payment. So Medicare patients, 85% of our patients at Mayo Clinic are Medicare patients because of the CMS waiver. When it comes to private payers, that is negotiated. You have to go to each one. There's no national standard right now. So you'd have to sit down with the commercial payers and say, hey, would you pay for this? Do you want to pay for the acute stay? Do you want to pay for a 30-day bundle where we own your patient for a bit longer and make sure they get taken care of and not come back to the hospital? Those are the current payment models right now. People were waiting for the national legislature to continue the waiver, which we got with the omnibus package just at the end of last year. Now we're able to show again the quality metrics and some of the cost savings over time. That will change, I'm sure, what Medicare and commercial payers do in the future.
Thank you. Dr. Chang, did you want to add to that?
Yes, Dr. Maniaci hit the nail on the head when it got decoupled from the public health emergency and put into omnibus healthcare package. It was huge for us because essentially it gave us another 2-year window in which we could capture data. And one of those key components for data is cost. Right now, we get the same reimbursement as if the patient is sitting in the hospital. And the way I explain the program to patients, it's the 3rd floor at Tampa General is now your home. It's the same. The reimbursement is the same as it stands today. But from studies that we've been a part of and submitted data to so far show around 1/3 reduction in total cost. And that's what we aim to sort of collect. We know that an inpatient, I just talked about the cost of the infrastructure for a hospital. We know that the cost can't always be the same, but right now we need that support to help grow the program and collect the data and then come back and say, this is what we've been able to do and show a reduction in overall cost of care, which is extremely important.
Additional questions? Senator Harrell, you're recognized.
Just wanted to ask you to address Medicaid. Do you receive the same reimbursement? I know if you're part of an MCO, that how are you paid through Medicaid? Is it commensurate?
Dr. Chang or Maniaci, we'd like to.
Sure. So right now, we would either have to negotiate with those individual plans or come in front of you guys to get support to help us take care of Medicaid patients in the hospital at home program. Some things that we've tried to do is work with, in Tampa, we have the Hillsborough County Healthcare Plan. So we've met with the county and the board that manages that plan to see how we can start to get into that population of patients. I think one thing we want to make a hallmark of the hospital at home program is equity, to make sure that everyone has access to this type of program. So I think that's really where we could use some of your help in the future, is figuring out how does this fit into the Medicaid plans in the state of Florida, and then figuring out for individually how we approach payer by payer and what is a good strategy for us so we can get commercial payers on board too.
Thank you. Additional questions? Senator Book, you're recognized.
Thank you, Madam Chair. And thank you, guys. It's wonderful to get real-world knowledge of what's happening on the ground. And it's wonderful to see how excited you get when you talk about, real 5-second information from a heart monitor. It's very exciting to see you excited about what we're able to do for patients in the state of Florida. I guess my question is, there are co-occurring illnesses or issues for a patient, is this, people can opt out, or is this maybe not the most optimal situation for them to be in? And what are we doing for some of that wraparound? Because if you're congestive heart failure, some of these other things, like this is, a longer term diagnosis, there are other things that should probably be put in place. Are we doing that as well and helping to support the families who are there caring for their loved ones? Thank you, Madam Chair.
Dr. Chang, jump in, I can
the,
tell.
the wraparound care is so important. So we've created teams such as like a transitional care team that once they've graduated from the hospital home program, there's communication between our team and the transitional care team to go ahead and make sure that follow-up appointments are made and the patient has medications and access to transportation. Sometimes we'll even take food out to a patient if they have a food insecurity, and we know that that's going to help them get over the hump and try to set them up with the community resources that are important to that patient population. So I think that transitional care component is one of the reasons why readmissions are so much better. And, the patients don't forget our phone numbers. So even if they don't have a resource, I'll give you the perfect example. After Ian, we only had maybe about 20 patients go through the program, and we called each one of them, even if they were discharged a month, 2 months previous, and said, how are you doing? And a patient's nebulizer, which is a breathing machine, broke during a power surge. And so she lived close to my house. So I grabbed a machine and I just took it out to her. So it's kind of extending that care. It's really more of a family concept of care. All of our patients are part of us. We'll have to see how that goes as we scale the program, right? That's always a concern, but we really want to keep that personal level touch. But it's a great question.
Additional questions, Senator Brooke? Yes.
One follow-up, and I think you've touched on something that I know is very important to all of the members on this committee. We've talked a lot about transportation, particularly Senator Harrell and I. When it comes to some of the healthcare issues, transportation is tough. It's hard to make sure people are getting to where they need to go. So that is something that is unique to this program.
Dr. Chang.
I didn't answer your first question. I think one thing we want to highlight is that a patient has to consent to be accepted into the program. So there are a lot of dynamics that go into safe care at home. We have to sort of talk to the patient, and also we try to engage the family too if they live nearby or with the patient, because they are going to be our advocates and our help, our second set of hands within the home. And so those two dynamics, if we feel that it's not going to be safe for a patient, or if they don't consent, of course, they can receive great care inside the walls of our hospital.
Thank you for asking that question, Senator Brooke, because I had a note on here about patient eligibility. I think that was a good question. You have additional questions?
I just want to also just make sure, so there is a special component for the people in your program for transportation, right?
Yes, we
Dr. Miller.
transport
Go
all
ahead.
the patients. Yes, that's exactly right. So if your patient requires transportation, we have tiers of transportation. If you require an ambulance and paramedic transport, we can do that, a medical transport, or just a car transport. You can have different transportation, and that goes to all the needs they need in the home as well and afterwards. And you have to think of this as not just hospital level care is what we're doing, but this is a tiered system. So if it's not hospital, it's remote patient monitoring, primary care provider in the home, and other different levels, so people can move between levels as their care escalates or as it goes down. You have that connection, but it's the right amount of care for the right patient at the right time, not too much, not too little. It's baby bear's porridge for what you need in healthcare.
One more question. I like the baby bear's porridge.
You're recognized.
And to Senator Harrell's point about, the doc in the box, and we've been working with some of the folks down in regional and have seen some of that, but can you draw a picture if somebody needs a hospital bed? Do they get a hospital bed? Do they stay in their own bed? Like what? I know we're getting the leads and the thing. What does this look like?
Dr. Maniaci.
Yes, so there's an assessment, both medically by the physicians and medical team in the hospital. Are they the right patient for the program? What do they need in the home medically? And then there's a social screen. What does the house look like? It may not be the ideal house in our mind, but as long as you have a roof and power, we can put a hospital home. We can have the internet connection. We can set up all the technology. We do a safety assessment. Are there fall risks? Are there 40 cats in the home that we're going to get in the wound or something else? And we help those patients out. We clean homes. We deliver meals. We set up a safe environment, not just for that hospital stay, but for afterwards. That's part of the program too. I get to see, you become an N of one. You're just one person. You're not on a big long floor. I see you in your chair with your dog, with your family, what you eat, and I build your healthcare plan for you, and I make sure that sticks over time so that you stay healthy, because that's ultimately what we want. That's what keeps you out of the hospital over years.
Additional questions?
just the comment of the scalability. I think what you're saying is remarkable and special and wonderful. And I would hope that if I ever had to be in that situation, I would be able to qualify to be in that place where Dr. Chang could bring me my nebulizer if it broke. But the scalability of it is something that, we continue to look at and change and address. Thank you. And thank you for what you guys are doing. Appreciate it.
Thank you. Senators, additional questions? Anybody? Senator Osgood, you recognized.
Thank you, Madam Chair. As I was listening at you, the equity piece is certainly very important to me, and having had a recent experience being a caregiver for an elderly granddad that raised me, it's no way he could have navigated any system, or he would never have agreed to put his name or to sign up for anything. So when you get elderly patients that are like that, and you said they have to sign the consent, sometimes they're not mentally able to sign the consent, and they may not have a power of attorney. What do you do in those cases?
Dr. Maniaci.
So first we do, with every patient and everything in the hospital, we do try to assess the ability to give consent. But we also turn to family members and others in the house as well. We're going to send this patient home, often with family. We want to make sure everybody's on board and knows exactly what to expect, not just from the medical care side, but the people in and out of the home, the nurse practitioner, the labs, everything that we do day to day. If there's hesitation, we answer questions. And if they go home with the program and 5 minutes into it, they say, this is not what I expected, or I did not understand, we move them back to the hospital. There is no pressure to keep them in the home setting. I have no ego in this. I just want to do what's best for the patient. If patients need help, we do have case management, social workers, and legal teams that can help the patient make decisions and say, hey, this is the information you're getting. If they need others to assist them, we provide that as well. But ultimately, I want this to be on the patient and the family to make a decision together that this is what they want.
Thank you. Additional questions?
I do.
Senator, you
I have
recognize?
2 more, please.
Gentlemen, could you we're getting some feedback. Are both your mics lit right now? They're off? Okay, well, we'll figure this out. Thank you. You recognize, Senator.
Thank you, Madam Chair. And the case management piece was key. I'm glad I heard you say that. But I was referring to someone that lives alone. I just know that we have a lot of aging individuals in the state of Florida, and it is horrific navigating the system, getting care for them. They cannot do it on their own at 80 plus. It's just intimidating. And I'm going to switch. You talked about nurses and employment. How do you provide the human resources to this? If we have a major shortage with nurses and different things, it talked a little bit through that piece. And do you ever lose people that they go to other states because they get paid more wages? Just how does, if in my mind I'm saying, okay, if we're short already in the hospital and then we have this wonderful program, are we transferring employees? How do we get more employees? And then my final question that you can ask, how do we get students in the loop to start participating with these jobs, from technology, the medical side, et cetera?
Who wants to go? Dr. Maniaci, you recognize.
Okay, I'll start with nurses, and Dr. Chang can talk about education as well. So you're right, we're at a critical shortage of nurses, and by the waiver and what we need to do, what's right for the patient, you need 2 physical touches at least a day in the home hospital. We need somebody, boots on the ground, to see the patient. But if you think about what a nurse does in the hospital, about 40% of their job is true nursing bedside care. Another 30% is what's up here. And the other rest of it is a lot of stuff that they shouldn't be doing at all. So what we've done, and what SB 1222 helped us, is using a paramedic under the supervision of a nurse to go in the home and do some of those things. The nurse can watch and say, do this, do this, do this, and the paramedic does it. So I don't need 3 nurses across the city. I need 1 nurse supervising 10 paramedics, and that adds a portion of that. And then I can have my 1 traveling nurse go around and do their nursing assessment. It's a combination of forces. I also have nurses that are about to retire, elderly or disabled. They're not able to physically practice on the floors anymore, but they can sit in front of a computer and use all that 50 years of knowledge in that head to spread their knowledge and help other, practitioners throughout with this program. So that's really, I think virtual care is going to save nursing in the future, both in hospital at home, but also in physical hospitals as well. There's plenty of work to go around, and we have to save our nurses for that. So this is really important.
Dr. Chang, did you want to add something to that?
I would agree wholeheartedly. And I think the other component too, just to touch on the staffing, since it's such an issue for us and over the last year, is that we haven't had a problem finding nurses because it's sort of changing the model of care, and they're sort of excited to leave the care setting that they know and do something completely different. How long that lasts, we'll see. To your second question around education, we've already worked with our residencies and our nursing programs from an educational standpoint to have student rotators on our service so they can come out and experiencing it. And we're actually in the process of designing an actual course and curriculum for residents to actually create a rotation where they're coming out with us and providing care. So we see that as the future, and of course, our future healthcare providers are a part of that.
Thank you, Madam Chair.
Thank you. Members, if we might take a brief moment of personal privilege. I'm not sure who the young group of Floridians in the back of the room that's visiting us today might be, but we would like to welcome them and appreciate their interest in state government. So thank you for being here with us today. All right. Do we have additional questions for our first panel? They were answered. Thank you. Anybody? Additional questions? Well, Doctors Chang and Maniaci, thank you so much for traveling to be with us today. You answered all the questions I had notes on, so thank you, committee, for asking such great questions and engaging in this conversation. It's interesting. Our next panel is a conversation about emergency department diversion, and I think it was mentioned in our first panel that keeping patients healthy, sending them home and keeping them in great spaces where they stay healthy should be hopefully a contributor. I know you'll get more data on that as the years proceed, but we really appreciate your time and invite you to stay with us for the second panel. And members, as I just said, our second panel involves emergency movement diversion. A lot of patients, we've all seen it across the state of Florida, are using emergency departments as their primary or non-urgent medical care. Around our state, hospitals and other healthcare providers and facilities are engaging in innovative ways to treat such patients, to keep such patients outside the emergency room, and through Medicaid programs, through our other insurance, really doesn't matter. They're coming up with innovations that help us keep patients out of emergency departments and correctly put them with the physicians where they need to be seen. Today, I'm delighted to say we have three panelists who've accepted our invitation to travel to Tallahassee. We have Danielle Drummond, who's the CEO of Lakeland Regional Health. We also would like to welcome Ann Clausen. Ann is the CEO of Central Florida Healthcare, and Dr. Wilson, who's with us from Tampa General Hospital. So what we'll do is we'll just go down the panel and ask you all to give us a brief presentation of the unique work that you're doing at your institutions, and as usual, we'll open it up for questions. So, Ms. Clausen, would you like to begin?
Yes, thank you so much, Madam Chair. I appreciate the opportunity to speak for a few minutes this morning. So just to give a little bit of background, federally qualified health centers, which Central Florida Healthcare is, has provided high-quality, comprehensive primary care services in the medically underinsured communities for more than 50 years. So in Florida, there are 54 FQHCs that treat 1.8 million patients at more than 750 locations statewide. And so we do a lot of work across the state of Florida. FQHCs are provided some funding under HRSA, under the Health Resources and Services Administration. So that's where we get some of our funding to treat the uninsured and the underinsured. We serve about 30 million patients, 9 million children, and 1.5 million homeless, and about 400,000 veterans across the state of Florida. So as an FQHC, we are required to report quality measures to HRSA. We focus a lot on diabetes, hypertension control, low birth weight, cervical, breast, and colorectal cancer screening. We do sealants for children. We're very involved in the schools, depression screenings, tobacco screenings, and childhood immunizations. FQHCs are protected under the Federal Tort Claim Act deemed status, which means that we are provided through the federal government for malpractice insurance. And that allows money that would have been spent on malpractice insurance to go back into the community. So we have to apply each year for that status. Central Florida Healthcare, our service area, serves Polk Highlands and Hardee County. and we have an active board of directors that are volunteers in our communities, 3 communities. And so we've had a lot of growth over the last several years. We now have 15 locations in Polk Highlands and Hardy County with 535 employees, which consist of physicians, APRNs, dentists, hygienists, so a full staff of clinical support that provides those services in each of our health centers in Polk Highlands and Hardy County. Last year, we saw 68,000 patients with 211,000 visits. So FQHCs stay very busy serving the patient population. Central Florida Healthcare is Joint Commission accredited, so every 3 years we have to go through that process, and we are also primary care medical home certified. So when you talk about a federally qualified health center, our goal is to keep, part of our goal is to keep the patients healthy. So we serve the entire family, and so we serve all the way from birth up to the Medicare population. And so we treat the whole family, and in our FQHC we have medical services, dental, behavioral health, OBGYN, optometry, lab and x-ray, pharmacy, and case managers in each one of our locations. And those case managers and navigators work to ensure that those patients, if they have coverage or if they qualify for Medicaid, if they're uninsured, if they need to go on the sliding fee scale, those case managers are very important in each one of our health centers. So we also, in talking about partnerships, we partner with Lakeland Regional Health. We partner with many of the hospitals that are in our service areas of Polk Highlands and Hardy County. And so what we do as a federally qualified health center is want to ensure and educate those patients to come to us before they go into the emergency room, because we certainly want to keep as many people out of the emergency room as we can. So that navigator, that case manager, that relationship that we have with the hospitals in each of our service areas is very, very important to reduce the cost overall and reduce patients from having to go to the emergency room. And so there's various ways we can do that with case managers, again, working very closely with the hospitals, with discharge plans. Once they've been released from the hospital, a lot of times they become our patients, and we are able to treat them. So we also partner with, we have a lot of, we're involved in the residency programs through FSU with Baycare, and we have a lot of students that are in the different colleges that rotate through our FQHCs and then hopefully become employees of ours. That's our goal in working with the many different hospitals. As I mentioned, we have our payer mix. 54% is Medicaid, 20% is uninsured, and then we have about 17% that are other third party and about 9% that are Medicare. And so, again, we're, have that opportunity as an FQHC. Some of the things that we have done differently since COVID is we have mobile units that go out. We did a lot with the COVID testing and screening and vaccinations. We do a lot with the Ending Hunger Initiative through the United Way. So, the FQHC has that opportunity to work very closely in the community, build the partnerships, and then work with the hospitals to keep the patients out of the hospital and as healthy as possible. So thank you very much.
Thank you. Ms. Drummond, you're recognized.
Thank you, Madam Chair, for the invitation to be here today, and thanks to all of you for your interest in this important topic. So just a little bit in the way background about our organization at Lakeland Regional Health and the community that we serve in Polk County. We are an 864 licensed bed hospital located in Lakeland. We do have about 40,000 admissions per year in our organization, but along with that, we do about 200,000 emergency department visits annually, which makes us the second busiest single-site emergency department in the entire country. Why is that? There's a few reasons. One, our capabilities and our geographic location do allow us to be able to provide a lot of care that's necessary in our region. Being the only trauma center in the Tri-County area that Ann referenced is one of those. Again, we have a lot of capabilities in neurosurgery, cardiovascular surgery, et cetera, that really allows us to be able to provide the care that is needed in Polk County and beyond. But also at the same time, we recognize that there are a lot of patients that do rely on our emergency department for care that could be delivered in other venues. But that really then ties back to the physician shortage that we face in Polk County. So when you compare the number of primary care providers to those across the state of Florida, we're about 1/3 shy of the per capita primary care providers for our residents that you would see for the state average in Florida. If you are to look at behavioral health providers, that number drops about half. So we have about half as many behavioral health providers per capita as you would see across the rest of the state. So what have we been doing to try and address that? We have been working aggressively over the last several years to try and grow and expand our physician group and that physician network that we have, either through the Lakeland Regional Health Physician Group or in partnership with organizations such as Central Florida Healthcare and other physician providers in our area. One example that I would note, back in 2012, we did establish, again through support from various parties, including the state, and I know something that Senator Burton was closely involved with too, a family health center across the street from our emergency department. This location does allow us to be able to provide care sort of in real time, but then even more importantly, to provide that continuity and really establish that patient-centered medical home. A patient-centered medical home really is a venue where a patient can establish with a primary care provider and have that consistent access. Also need to ensure that we're providing access outside of normal business hours, because we recognize that that often can be a challenge and what may prompt patients to go to the emergency department. So that has proven to be very effective. We have cared for 160,000 patients in that venue since we opened its doors. So we feel that that is a great example of how adding that site of service can allow us to be able to provide better access for patients in a more appropriate environment. The other thing that I'll just comment on as well that we're really excited to be moving forward with later this year actually is to become an academic medical center, a teaching hospital. We've been on a journey to become a teaching hospital for nearly a decade now, and really just very excited to be able to open the doors to 7 programs in July of this year. Most of these are in the primary care space. And again, we recognize that being a teaching hospital will allow us to have an infusion of residents during their training time with us. They'll be able to see patients out in the ambulatory setting to improve that access. Of course, we're hopeful that a number of these residents will want to stay in the area once they complete their training, which again would bring us more physicians to help address that gap as well. In addition, I think there's a lot of great reasons that, we should be a teaching hospital. We think we're one of the largest hospitals in the country that does not teach today. So we really feel it's a part of our mission to open our doors to that next generation of physicians as a part of this. And again, we're hopeful that all of these efforts will in turn also allow us to turn the needle a bit on the high volume of emergency department visits that we see today in our organization.
Thank you. And Dr. Wilson, I'm going to ask you to speak, but I want to make sure everybody looks at your bio a little bit. You're not here as an emergency room physician. You're here as somebody who trains others to become emergency room physicians. So I'm thinking you've got some deep thoughts on what we can do in the state of Florida to keep people from having to cross that threshold. So I'm really interested in what you have to say.
And it's funny you say that too, Senator, and thank you so much for doing this, and thanks for having me, and thanks to the committee. But it's funny you say, because I was going to start with an anecdote about my training and how much things are different now. When I trained in emergency medicine, we really thought of emergency medicine as a box in a hospital that people came to, and we ruled out emergencies. But I think everybody here knows that is not exactly how the healthcare system works. And we have 2 choices. We can keep on trying to be a box where we try to rule out emergencies, or we can try to address what's actually happening in the healthcare system. And I think what we've started to see at Tampa General and other innovative hospitals is that what emergency medicine has started to change to address the needs of Floridians and address the needs of our patients. And that's happened in 3 major ways. One, I think, is that we're starting to respond to who actually comes into the doors. I spent a lot of my time training and thinking about things like heart attacks and strokes and sepsis, but we're in the middle of a major opioid epidemic here in the state of Florida. So perhaps my emergency medicine team needs to receive some addiction medicine training and understand how we do addiction medicine. Number two, we've always thought about it again, inside a box. Even our EMS colleagues, which we train and work closely with, kind of think about it as rapid resuscitation and bringing people into the hospital. But perhaps we have to move outside of the box. Perhaps we have to move outside of the hospital doors into a pre-hospital space and deliver care in spaces we haven't done before, because there's people who are sick and need even emergency medicine, doctors, emergency medicine care outside of the box. And perhaps we can take those people and coordinate them to the right place at the right time. So what does that mean? It means starting to work with community organizations we've never worked with before. I've spent the last 5 or 6 years working very closely with substance use organizations, the community, signing contracts, building partnerships. We just started a large initiative with Central Florida Behavioral Health Network, a managed entity. I think one of the first hospitals to do that. What that program is, it's a 3-day-a-week mobile program. I know one of the senators talked about HIV care. That's also my passion from research and academics, is HIV care. We provide HIV care, hepatitis C and HIV treatment in a mobile setting, while we also address harm reduction and drug use as well. Through that, we've done some amazing things. We've taken people who would have definitively been brought into a hospital, admitted, probably left and come back multiple times, and been able to manage their care through what I would consider building coordination strategies, kind of building a network outside of the hospital through new partners to be able to manage those patients outside of the hospital space. Because either A, those people were not going to come into the hospital when they needed to, and they were going to get sicker, and then they're going to be very sick, very difficult to care for, so we may as well go to where they're at. And that started to look like both mobile clinics, using our pre-hospital colleagues. Perhaps we have people who have HIV who just won't retain in care, but maybe our pre-hospital colleagues know where those people are and know how to help us find them. And maybe they come to the emergency department, and I could either see that person in the emergency department and say, hey, you're not on your HIV care again, and send them home and have them come back again, or I could treat them or start to establish care for them. And so we started to think about the emergency department as this place, not just to divert the visits before they get there, but if they do come, how can we act as an unscheduled hub of care? And I think that's the big revolution that's happening right now. So you might be sometimes an entry point as the ED, but how can we start to think about things like telemedicine? Telemedicine has been hugely important, by the way, for even emergency medicine. COVID got us to the point to start doing things in telemedicine we never would have done before. So we started by discharging COVID patients and following through telemedicine visits with our ED team and with our transitions and care team at Tampa General. Now we've started to expand in all kinds of spaces. Maybe I see you for opioid use disorder in the emergency department, start you on a medication, send you home, and start to follow you through telemedicine while the transition and care team starts to work on getting you placed into a clinic. I just diverted an overdose and a repeat visit for opioid use disorder. And we have a specific patient we like to think of who had endocarditis, a heart infection. That's a very lengthy admission if we don't take care of that patient outside of the hospital. So we're starting to see these things actually happening in real time through mobile units, community partnerships, telemedicine, and then virtual care is what we're starting to really work on now. This is all happening in partnership with a rapidly expanding urgent care system through TGH that does see Medicaid patients, which is not normal for all urgent cares. But having that ability to see those patients at those kind of spaces as well opens up major access points for those types of patients also. So we're starting to see this rapid expansion of both where we seek care, how we deliver care, where we deliver care, and what we think of as the emergency medicine wheelhouse, even to the point of having, when I started emergency medicine, we might have had a social worker for a few hours a day. We have a whole pod, we have a pod system in the ED. We have a whole pod of social workers now and case managers now. And what are they doing? They're helping us in real-time scheduled visits. They're helping us link to our transition to care center to make sure those patients have at least a telemedicine check-in after they leave the ED, especially for an ambulatory care-sensitive condition. We're seeing this type of care coordination start to happen. We're on the cusp of a real revolution in how we're delivering care. So I'll stop there and answer any specific questions you folks may have.
Look who has a question. Senator Harrell, you're recognized. Yes, ma'am.
Thank you. That is just amazing. And I know down in the West Palm area, we have a peer program in the emergency room where, especially on the addiction side, when you have someone come in and overdose, we have a program where they actually have a peer go home with them if they're willing to do that, which is excellent. But my question is, and I love all this idea of being able to shift people to other sources of care and follow up. But my question is, as we move to that, and I would love to have us start compiling all those options and making them, if there's legislation needed, to make it all happen better and easier, we should be all involved in doing that. But I come down to the basic question. Under federal legislation, you have a responsibility. You cannot turn anybody away. You have things that you have to do, and there are liability issues that come with that. When you start shifting people out of the emergency room or to an urgent care center, then what happens to that liability, and how do you deal with that? If someone comes in and you shift them off to an urgent care, who pays for it? Because in the emergency room, you bear the cost of that, and no matter what, they have to get the care. When you shift them, who bears the cost? And then also, where does the liability end?
Thank you for the question, and I'll just address
You
peers as
recognize
well.
Dr.
Oh,
Wilson.
I'm so sorry.
I say Dr. Wilson and Ms. Drummond could probably answer the question as well, but please begin.
Thank you. Apologize. To address peers really quickly, too, just for the committee to understand, certified peer recovery specialists have been huge in helping with our opioid use disorder epidemic right now. We've also placed those into the emergency department through the Help of Central Florida Behavioral Health. They've been tremendous in helping us link people to care and also following through telemedicine. To answer the second part of your question, I think this is why it's really, I think of the emergency department as the red zone in football. And this did not go well for my team last night, but there was an interception in the red zone anyway. So, I think of it as the red zone in football. I can only stop the offense so many times once you make it to the red zone, right? And so when you come into the emergency department, you're right, we have an MTALA. It's a federal mandate that says I have to do a medical screening exam and rule out an emergency medical condition. As a matter of fact, that's actually why a lot of emergency medicine physicians go into emergency medicine. We want to be that safety net where we can know that people can come to us and receive care regardless of ability to pay. We're going to be there for them. So there's an aspect of that where we know we're going to see people and need to treat them and take care of them. And that's why I emphasize that we can't lose the fact that that is also an opportunity to connect that patient across the healthcare system. So maybe we do manage the patient that time because they're at the point of an emergency medical condition. But how do they get there? Right? Where was their access before that event? And what can we do for that patient to link them to better care at that point? I think where these models have not worked quite as well, maybe 10, 15 years ago, is the idea of having a patient come into the ER, quickly doing a medical screening exam, and then trying to shuffle them off somewhere else. That doesn't work as well because it opens up a lot of those liability points, and they're already there, right? The opportunity cost for me to see a patient's already arrived in the emergency department is not that high, and they've already burdened the cost and healthcare system, and they've gotten to the point where they have a condition that leads to emergency care. So it's probably not at the point of that entry into the healthcare system that patient should be shuffled off. But if we have a patient who shows up in the ED, we should think about all the wraparound service. We should assess for social determinants of health. We should assess for where that patient could be managed best. Do they have a primary care? Can they link with an FQHC? What should we do for that patient next time to make sure we're going to actually manage the condition, not just treat and street as the old term used to be called?
Ms. Drummond?
Yes, thank you. And on the topic of the peers, we equally have seen some, really great success in that program, and we've, also made a big investment recently in behavioral health with a new freestanding facility on our campus. And again, I think that's been, very important for that particular patient population that you referenced. So I would just add that to that piece of the conversation. But yes, I think while we have worked in some instances to be able to evaluate, certain protocols that would allow us to still be compliant with what we, need to do with respect to that emergency care, and see if there is someone that is, presenting that is in a situation where perhaps they could be seated elsewhere, that you could, work through that process. So I think that exists, but at the same time, that's really not addressing the root cause of the issue, which is why is there a patient that's presenting to the emergency department in the first place for, either a condition that could be treated in a different setting, or how do we establish them with that primary care, that medical home, so to speak, so that they do have consistent access, so that hopefully their particular condition doesn't escalate to a point where they're really requiring that emergency level of care. When you asked about funding, our family health center that we did establish across the street, again, so that we would have someone that after they've been treated in the emergency department could go somewhere, because they may not have been eligible to be seen anywhere else in the community. And we knew that having that ability to go see a primary care provider after that ER visit or after that inpatient admission is really going to be critical to prevent that particular individual from coming back. And that is something that we did fund out of our operations because we recognize the importance that was going to have for the overall community and the health system. And it was just something that we felt aligned with our mission.
Thank you. Additional questions? Additional questions? Senator I see you back there. I'm going to start taking names here. Taking names. Well, since he is the vice chair, Senator Broder.
Even better. Thank you very much, Madam Chair. Just curious, as we think about the evolution of care in medicine and we're trying to decrease the number of folks that are coming in, are you worried that there's going to be a point with all of the treatment that you might be doing through the emergency room that you're conditioning the public to just go there first? And so as we try and make sure that people are accessing appointments and going to urgent cares instead of emergency rooms for things that are less acute, where is that balance? Or do you believe that over the next 20, 30 years, folks will just go to the emergency room first before making an appointment? Where's that? Where do you see the evolution, I would say, going of folks that don't normally access an appointment in a medical home and would have a more traditional appointment-based system?
Ms. Drummond, you recognize.
Sure, I can start. Yeah, I agree with you. I think a lot of it is around education. So, I think we've been out trying to, we have campaigns out there as part of our marketing and communication strategy to sort of educate of, this is what's appropriate for, primary care. This is what's appropriate for urgent care. This is really when you need to consider the emergency department. We've also tried to ensure, I think when someone can get established with a primary care provider, I think that there's that comfort there. So again, I think we've looked at ways of, having that particular location be a little bit more flexible. And, we take appointments, but you also have the ability to walk in or come in after hours. I think introducing additional providers in that setting too can be helpful. But then I think we also are sensitive to the fact that I think there are, and some of it could be generational or otherwise, there's certain individuals that maybe just don't really feel like they need that primary care provider, and they're more, I want to go and access convenient, high quality care when I need it, but really only think about it then. So again, I think those are the times when we say, hey, if we have a walk-in option, if we have an urgent care option, let's make sure that the community knows that that is available to them, so there isn't that reliance on the emergency department in the long run. So I feel cautiously optimistic that that word is getting out, and I think as we've seen growth in our primary care and urgent care settings at a faster rate in our emergency department, I think we have some good evidence to be able to show that that message is starting to get across. But I don't disagree with you that I think it's definitely a journey and not a sprint to be able to get there.
Dr. Wilson would like to answer too. Do you want to hear? Okay, Dr. Wilson.
Yeah, Florida is getting much larger by population. Hillsborough County, Polk County are getting a much larger population, and with that becomes people who have more morbidity, more diseases. I worked a clinical shift just yesterday. I saw about 20 patients admitted, 7 of them to the ICU. So we have a lot of sick Floridians too coming in. And I think what we have to do structurally is build out systems where people go where they know best to go, right? And people are going to go where it's easiest and where they trust, when they know they can receive great care. And so if we build out equitable systems, meaning it's just as likely I can walk into TGH Urgent Care Fast Track as another person can walk into TGH Urgent Care Fast Track or another type of system like that, I think what's going to happen is we'll start to see people recognize our EDs are very, very busy with very, very sick people, and it's getting, the acuity of our EDs is getting sicker and sicker each year. I think Lakeland is seeing the exact same thing. It's the number of transplant patients we have, the number of people with comorbidities that we have, people with LVADs and other disease states. It's quite a bit of people. So I think we just have a structural responsibility to create an equitable system where people can go other places, and they'll go there.
Ms. Clausen, you want to add to it?
Thank you, Madam Chair. I would like to also add to Daniel and Dr. Wilson. I think the continued education and how we can collaborate together is extremely important. I think federally qualified health centers are certainly an answer to a lot of what we can do, having patient-centered medical homes, to try to educate the patient to come in and be seen at an FQHC, and then if it needs to go to the hospital, we certainly can partner with the hospital. But I think all those efforts that we can make together, FQHCs and hospitals, our collaboration together, and first and foremost, the educating the population on the need to stay healthy is part of what we're talking about.
Follow up, Senator Broder, you good? Okay, additional questions. Senator Burgess, do you have a question?
I know now why, thank you, Madam Chair. I know now why he's vice chair, because he literally kind of took the words out of my mouth. So good job. So I've seen firsthand through like Premier Community Healthcare in our area in Pasco County and their expansion and their growth. And I think it speaks to both the need and the success of these federally qualified health centers. So I was going to piggyback, I guess, on the messaging part. What can be done to help promote this, get this, arm people with information that lets them know, hey, I can do this. I don't have to go to, and I can do preventative care. I don't have to go to the ER. You probably just answered that. So I'll allow you, whether or not you want to piggyback on your previous answers.
Would you like to elaborate, Ms. Clausen?
Yes, thank you, Madam Chair. So to elaborate just a little bit more, I think, because I don't know in this room how many people really knew what an FQHC is and what we do. I think a lot of times we're referred to as the free clinic down the street, the last place to go for health care. And I think the fact that we have very qualified physicians, dentists, a big part, too, of what we do is have the 340B pharmacy program. And so being able to keep our patients healthy and get medications at a discounted cost is a big part of what we do, because that ties into the overall health. But again, I think collaborative efforts on educating the population, to be able to have a patient-centered medical home and then work with those hospitals when the need is there to truly be seen in the hospital is very important. Thank you.
Additional? Senator Osgood, you're recognized.
Thank you, Madam Chair. And thank you for this wonderful, amazing presentation. I've been working a lot with my good friend Shane Strom, who is the new CEO of Broward Health, and he's putting into place a lot of these mobile units. And my concern is the street people, the homeless people that don't have insurance, and 2, children. Are there any restrictions when you're going with these mobile units in these environments that's out of the box when it comes to treating children? That's one question. And then what does a homeless person that does not have insurance, that's not connected to the system, that normally traditionally go to the hospital, they know they can stay 3 days and then normally they transition, they come out for 2 days, they go back. Certainly we don't want that, but are you able to treat those homeless individuals outside of the hospital environment?
Dr. Wilson, I think that's yours.
Thank you so much for that question. That is a passion point of mine, and that's exactly what our mobile units do. We actually, on the mobile units that operate 3 days a week, we have a complete social determinants wraparound service team. So we're not just doing wound care and HIV testing and harm reduction. We're also doing food assessment and food pantry. We're also doing some clothing. We're also asking questions about family and children and what children's safety and looks like. Children can come. We can we work with Ybor Youth Clinic. So one of the days that we do this operation, we're actually right next to Ybor Youth Clinic, and we have an official internship program for a licensed mental health counselor who works at Ybor Youth Clinic and with us. And so that's able to liaison the pediatric population, the adolescent population, over to the Ybor Youth Clinic for us. Then we also have healthcare navigators who are stationed at our sites as well. And those healthcare navigators can either, put people into, a market plan or we have the Hillsborough County Healthcare Plan in Tampa. So a lot of our homeless population is able to go into the Hillsborough County Healthcare Plan in Hillsborough County. But I think that's exactly it is. We know those patients are likely to either one of 2 things is to happen in the emergency department. They either access the emergency department because of a social determinant need, but maybe not quite a medical need, or their medical needs gotten so bad by the time they access medical services, we're at a point where it's going to be a very complicated, expensive care. So now we've decided, well, let's just go to where they are at, hot spots, the locations we know that population is at, and see them there. We've developed some really great relationships with people that way.
Any additional comment on that question?
I have one follow-up.
You're recognized, Senator.
Thank you, Madam Chair. When I hear you talk about those partnerships, I work with a lot of interfaith groups that do a lot of that social service type of stuff with clothing and feeding. In your program, is it times that you go to those facilities on their calendar? Like I know at my church on the first Saturday in March, we're going to have this huge homeless give back day. And I'm thinking, have you seen it where you just go set up your mobile unit doing those events, or are you normally setting the agenda for the events because of capacity and the organizations are partnering with you? Like, what is the capacity? Because you could have 10 events going on, across the county at the same time.
Dr. Wilson?
We started with two locations on 3 days, and we picked those locations based on the population. We wanted to access some vulnerable populations, so we go to Ybor City, where there's both the Ybor Youth Clinic and Metro Inclusive Health, and so we purposely picked that location. And then we also utilize the Tampa General 30th Street Health Park site, which is where we see a lot of Medicaid and other people underinsured as well. With the new Central Florida Behavioral Health Partnership, we're going to be able to expand our operations quite a bit. We have done what we call pop-up operations. So where churches or other, community groups invite us to come, we do, if it's not on the same day we're operating anyway, we do come. Our team of volunteers and other services has gotten much larger. I'd be remiss if I didn't mention we do this in partnership with Tampa Bay Street Medicine, which is a University of South Florida medical student arm with some physician volunteers as well. So that gives us some more capacity. So with capacity, we're always willing to go when we're invited somewhere else.
Thank you.
Mm-hmm.
Additional questions? Anybody? Additional questions? Senator Davis, you recognize.
Thank you, Chair. You all talked about education, and that's what we've been talking about a lot from the panelists, education, education, education. What type of tools are being used to help inform the public about the options for care?
Ms. Drummond, you're reaching for the mic.
Sure. Yeah, I'd be happy to kick us off, and then I'm sure others can share some examples as well. So again, for us, I think we've tried to have a kind of broad stroke of getting out there through various means that we use for a lot of our marketing communication tactics. Be it through social media, our kind of email communications, other ways that we're placing ads. Really trying to take advantage of the opportunity that we have with that airspace to be able to educate and inform. But I also think we recognize that so much of this is grassroots as well. So maybe to segue a little bit back to some of the community outreach, but we have a congregational health network where we really go out into the area churches to make sure that we can send some of our providers and team members into those forums so that there is an awareness out in the community at large about the capabilities that we have. We also have been much more active recently in just some of our community health outreach in general. So you'll see us on various days at various venues and locations, just providing information about what are the services and capabilities available through the Lakeland Regional Health Network and other providers in the area, but really trying to think about where are the venues that people are going to be the most interested and willing and able to take advantage of that. The other comment I would make kind of on the previous topic, while we don't have a mobile unit per se, we have tried through our existing family health center and then for our new location that is going to house our family medicine residency practice when that opens later this year. We've tried to look at the geography that does appear to be underserved currently and then in turn becomes high utilizers of the emergency department to say how can we, through our facilities, try to get the care closer to the individuals that really appear to need it the most.
All of it?
Anyone else want to take that?
Ms. Clausen, could you, to that point, to that question, could you please elaborate how Central Florida Healthcare, how do you reach out to community members so they know you're there so that, so they don't have to visit Tampa General's Emergency Department or Lakeland Regional's?
Thank you, Madam Chair. So I think, as we all know, COVID was a terrible thing that happened, but we learned a lot from COVID. And I think what we learned was we could do a lot of things differently, and that differently was using our 3 mobile units to go out in the community to partner with churches. We have great relationships with churches now. We can reach out, find out, from who are the homeless. We work a lot with the HIV population. So being able to go out in the community has gotten our name out there as far as what an FQHC can do. Not just that we expect you to come to our 15 different locations, but we can go to you via the mobile units. We do a lot with the schools, the sealant program, so we've been very involved with the children. So that outreach piece we have found through COVID has been instrumental in being able to provide care differently and get our name out there and educate the population on what we do.
Thank you. Additional questions?
Yeah.
Senator Davis, you recognize?
Thank you. Continuing on down that road, how can the state health department be helpful in assisting promoting these different options of care to the residents? And once that's finished, Dr. Wilson, you mentioned in your presentation that we have a structural responsibility. Could you elaborate on that after the first question was answered?
Well, Dr. Wilson, you want to do a two-parter? Go ahead. How can this? We'll start with you, and then we'll move on to our other panelists if they'd like to answer. You recognize, sir?
Yeah, thank you for the question. I did mention the structural issue, and what I mean by that again is, if we're going to expect people to go to urgent cares, we have to create an ability for them to go to urgent cares, right? Which means the urgent care has to be in a location where people can get to. It has to be open at a time that people can go after work. It has to take Medicaid, Hillsborough County, whatever type of insurance is. The other structural piece of this I want to bring up too is, going back to when I trained or over the last, decade and a half or so, the number of my patients who had no insurance compared to some type of insurance or an FQHC partnership has tremendously grown, right? So we have made some progress in this, and I don't want to be remiss that we have made no progress, but where we still struggle, I think we have some structural issues to work out, is a lot of patients may have primary care access or even FQHC access, but where they run into some issues still is around specialty care. And there's, I think, some barriers around Medicaid and specialty care. Just to give an example, a patient example, I will often see people who are referred in from the community, from other places into the emergency department, right? So when I see people referred from other places to the ED, I kind of think this is a structural thing, right? They've been sent from another place to me for care. And a lot of times it's not because they didn't see a primary care doctor. It's because they did see somebody primary. Maybe they saw I had a patient yesterday who saw a dentist at the FQHC but needed a maxillofacial surgeon. And that was very difficult to get, a year out, basically. So they came to the ED. This is pretty common. I need a gastroenterologist. I need a nephrologist. I need a rheumatologist, right? Those kind of patients, we don't have quite an equitable system to get those patients a spot. And so they tend to come to the ED to access that. So I just don't want that to be missed when we think about who needs access and where. That's an important part of that. I don't remember the other part of your question, though, if there was one.
I believe, to paraphrase, how can the Department of Health be involved?
We actually work very closely with the Department of Health for a number of our initiatives. Again, we do HIV, hepatitis C, and we have such a volume of patients. It's hard for them to do all the STI, HIV, hepatitis C, without a partnership, right? So we have to be a partnership around that, and I do think that partnership can expand and continue to kind of grow into those areas of access in terms of both the kind of the work we're doing in the mobile unit, which involves STI treatment, hepatitis C and HIV, but it also involves some wraparound services too. So is there a role for some of those wraparound services at those DOH encounters? I think that might be an important place to go.
Additional comments from the panel? Ms. Clausen?
Thank you, Madam Chair. I'll just add that we work very closely in Polk Highlands and Hardy County with the Department of Health. But again, it's that education of where a patient may need to go for services through the Department of Health or come to an FQHC for services. So again, I think it ties back to that collaborative effort with partners. And so I find myself saying a lot that we don't compete with one another, we collaborate with one another. So again, it's that education and, what do you do? This is what we do, and how can we better take care of the patient?
Additional questions? One more question. Okay, Senator Davis, you ready?
Thank you, Chair. I just kind of saved it for the end. And I would like to end with Dr. Maniaci and Dr. Chang with the legislative ask. If there's anything you can ask from this body to help you continue to be successful. I know you heard the voices, and this committee is very happy to hear the results. So what is the legislative ask to help you continue to be successful with the home care program?
Keep in mind, we only have 15 minutes left, roughly. And Dr. Maniaci looks very excited to answer that question. You recognize, sir.
Thank you. Thank you for that question. It's an excellent question and why we're here, really. So we're changing healthcare, as you've heard, and it's decentralization of healthcare, taking healthcare away from the silos of hospital, clinic, emergency room, and moving it into the community. The problem is the regulations are linked to those buildings. That's what SB 1222 did last year. Paramedics, somebody who shows up when you have an emergency, who treats you when you're at your sickest. I could not really use in my home hospital program when you were just a home hospital patient because the law said I couldn't. We changed that last year. There are other things like that. Those are the regulations we're going to need your help on, is looking at the things that don't make sense in this new wave. We treat people without boundaries. People that need help the most are people that I could treat people with home hospital in churches, in homeless shelters, but the law says it has to be a permanent residence. It can't be that. So I'm handcuffed by that right now. That's what we need change from you guys, is to look at the great work we're doing. We prove the outcomes. We prove the cost savings. You help us change the rules so that we can treat everybody throughout Florida.
Dr. Chang?
I agree totally. I would say the second area of opportunity is with the pharmacy. So right now, under the Medicare waiver, the medicines that we deliver and administer in a patient's home have to come centrally from the hospital. So geographically, that limits us as far as how far we can go outside of the walls of TGH to deliver meds in a timely manner to patients' home. The Agency for Healthcare Administration in Florida did approve a specialty waiver because there's an interesting rule around how the medicines administered under an inpatient rule have to be administered in the hospital. So when we applied for this waiver with CMS, we also had to apply with the state, and they helped, and they said, yes, you can do this out of the program. But if we wanted to, let's say, decentralize our program and out of one of our urgent care fast track locations, create a SWAT team for hospital at home that's 40 miles from the hospital, we could distribute the meds from that location instead of having to come back to home base on Davis Island. So I think some rules around pharmacy and some flexibility as how we administer meds would be very helpful.
It would be unfair if we didn't let the second panel also see if you have asked them, do you have anything in particular that top of mind that you think the legislature might be able to help you with moving forward? Ms. Clausen, we'll start with you. No is an okay answer too, but I'm just...
Well, certainly, I think I've shared with you before too that the challenges are, to be able to have funding for brick and mortar, to be able to build, and staffing is always a challenge for all of us. And again, mentioned the pharmacy piece, being able to have affordable pharmacy for cost for our patients, continue our efforts as what an FQHC can do is very, very important for our patients. Thank you.
Ms. Drummond.
Yes, agree. I think certainly we have appreciated the support that have allowed us to be able to move forward with some of the programs that I spoke to, specifically around graduate medical education and the behavioral health needs. So I think the more that we can continue to focus on, some of the underlying root causes and making sure that we have good access, not only in the number of providers, but in the way those providers are available to those in the community that need their care, be it the uninsured or, those with Medicaid as their payer type, I think will be very important for all of us as we move forward to try and reduce some of the high cost utilization within the system.
Dr. Wilson?
Yeah, as we think about where these asks are, these needs are, they're really around where when we come out of the hospital and start to revolutionize and disrupt this care, that's what they tend to be. So if I have a patient who comes in and they have been trying to get a CAT scan of their heart to see if they have coronary artery disease, but they can't get the authorization to do it, they can't get the primary care doctor to get referred to the cardiologist to get the test, and the test has to be ordered by the cardiologist, they come to the ER and get it. I could easily arrange it through our CareCom center to go get the test. But once they leave the doors of the ER, if they're not inpatient, it's very difficult to get that test. It's very difficult to transport them to a place to get that test, right? So now we've got pre-authorization for diagnostic imaging and testing, and we've got the idea of transporting somebody somewhere else. And then I've mentioned specialty care as well. Specialty care, I think, is a real barrier for us right now.
Senator Garcia, you have a question?
Thank you. Yes, I do. For Dr. Chang or Dr. Maniaci, you mentioned that the federal government was very generous in the last omnibus package. Could you elaborate a little bit on that?
Dr. Chang.
Sure. So the concept of the hospital at home program came about in the spring of 2020 when we sort of saw what hospital capacity was doing with COVID in New York. And CMS sort of, in their wisdom, decided to say, we're going to open up this hospital at home waiver in which hospitals can apply. And with the over 6,000 or so hospitals in the United States, I think only maybe 250 of them actually have the waiver that our institutions have. And out of those, probably around 150 are actually actively seeing patients. And so that bill was actually tied to the public health emergency. So as we know, Steve will have to correct me, but I think it's somewhere around April was when it was set to expire, and the hospital at home reimbursement was tied to that public health emergency. So they had some other healthcare issues with the Omnibus package, but one of the issues that they added to was the ability to extend the hospital at home program and reimbursement for another 2 years. So that really afforded us, again, the window for us to be able to collect much more data on cost and quality as we move forward versus if that reimbursement stream was cut, then financially it wouldn't be feasible for us to continue a hospital home program.
Senator Harrell, quick question.
Thank you. I just wanted to make one particular comment. When we're talking about specialty care, I don't know if your hospital has a volunteers in medicine clinic or a volunteers, either one of your hospitals, or if you work with one, on the FQHC side, where they do, especially with specialists, they do have a volunteer status, and they under statute we passed about 15 years ago does allow them to be, they're not held liable. They have sovereign immunity when they do that. And I was wondering if either of your hospitals do have that specialty area through a volunteers in medicine clinic, and then the hospitals would be doing the testing that would be necessary.
Ms. Drummond?
We have a wonderful organization in our community called Lakeland Volunteers in Medicine that does what you described. They just can't keep up with the demand. So while it's a wonderful program, there's just not enough providers to be able to treat the patients that are either, uninsured or have Medicaid in some instances. So we've been working within our system to, increase that access so that the patients that we are seeing in the primary care environment that do require access to that specialty care, if they can't be accommodated by the Volunteers in Medicine program, we've been making that investment to increase that access so we can hopefully try and address some of these conditions before it results in someone needing to come to the emergency department or be admitted for the condition.
Thank you. Additional questions? We have a speaker too. Somebody who'd like to speak. So can we let's let this gentleman speak if he'd like, and we'll have time to go back to Dr. Wilson if that's okay, Senator Harrell. Mr. Alan Davidson is here. Would Mr. Davidson like to address the committee for a couple of minutes? Mr. Davidson, you are recognized. Apologize for not getting you in sooner, but this has been a very vibrant conversation here today.
Thank you, Madam Chair, and thank you, committee. I am Alan Davidson. I'm the COO for Central Florida Behavioral Health Network. Dr. Wilson mentioned us. We are one of 7 managing entities in the state. We are the largest in population, the second largest in land mass. So a couple of things that you mentioned today that I'd like to address. Funding. We serve the uninsured and the underinsured. So in the programs that you heard today, that's how we get to serve, and that's how we serve the safety net as for the state of Florida. Transportation, I am so excited to partner with Tampa General in the mobile buprenorphine program because we get to go, our funding, your funding that you fund us with gets to go into the underserved communities. So I'm very excited about that. And then for the hospital bridge programs, which we have at Tampa General and we have at Lakeland Regional, the peers that we've talked about get to go into these hospitals and then actually get to transport. Sometimes personally, the providers will transport, or sometimes they'll use Uber Health to transport the client back to a substance use provider. And then finally, I'd just like to say, we are really excited to partner with the governor on the CORE program and to expand programs like the hospital bridge. So thank you so much for your time.
Thank you for being here and providing that information. Members, any additional questions or comments? Thank you. Well, I'd like to thank all 5 of our panelists for traveling here to Tallahassee. As you heard from introductions of our members of our committee, many of us have served in health policy committees in the past. I hope everybody else learned something today because I know I did, even with experience in this. So we really appreciate that you're here. Look forward to continued conversations with all of you. And members, thank you very much for your engagement this morning. Seeing there's no other business before the committee, Senator Harrell moves we adjourn. If there's any objection, seeing none, show the motion adopted, and we are adjourned. Thank you very much.